Hello, everybody. Welcome to lecture on Chapter 9, the joints. By the time you see this lecture, you have gone through the appendicular skeleton lab, and many of these bones or many of these joints will have a familiar ring to it. So I'm recording this in a hope that you retained a good deal from the lab. And think about it, practical is next week. So please pay a good deal of attention to those bones. Lecture exam 3 is coming a little later on. You will reap a tremendous benefit if you have those bones and bone surface markings down pat. So focus on that first, but don't forget about lecture exam 3. And of course, this ingeniously crafted exam will have this joint chapter in it. So I'm going to go to a screen sharing. I have some clinical context and a musical context to show you in this chapter. So let's go through this. The first part will sound tremendously familiar. The second part, not so much, but let's start with the familiar part here. So what I'm screen sharing here is the first slide. And a lot of anatomical curiosities come from this definition of joints. Articulation is a point of contact between two or more bones, between cartilage and bones, or between teeth and bones. And when you add up the number of joints in the body, in the oral cavity itself, you'll see dozens of joints. Very surprising, the contact between teeth and bones. We'll say a few words about these, of course, as we go on. So joints have the function of holding bones together, but still allowing movement. There are a number of solutions that we'll see in a body. Sometimes the holding of the bones together is just minimal based on the corresponding shape of the bones. And what you see here pictured is the most complicated joint type, the synovial joint, where the bones are held together maybe by ligaments, but also we have this joint capsule, synovial membrane that we covered in chapter 4, comes to a functional importance here. And so we'll be looking at from very simple to this complicated type of joint, such as the synovial joints here. In the lab, in that third lab on the appendicular skeleton, we have looked at the types of synovial joints. We'll be looking at this here in a few minutes. In the second lab, we named sutures as example of fibrous joints in the lab, and the intervertebral disc as the example for the cartilaginous joints. We'll be following this kind of classification scheme here in lecture as well. And we'll be adding a few more examples to these classes. On top of that, it's important to know that joints are also classified based on movement. This is not super intuitive, and as you'll see in a few examples, this is not 100% true, but nonetheless, anatomists gave designations such as immovable, slightly movable, or freely movable joints. And we'll be seeing, especially the freely movable joints, that there's quite a bit of limitation on their movement, so it's not truly freely movable. But I'm getting ahead of myself. So bottom line, we'll be following structural classification scheme, mentioning the ability of this joint to carry out movement. So with fibrous joints, we have the sutures. We've seen these in the lab. But then we have these things like syndesmosis and interosseous membranes. So we're expanding the examples for fibrous joints. So what's a fibrous joint? When the two bones are held together by some kind of a fibrous connective tissue. Let's take a look at these fibrous connective tissues. For the sutures, at the bottom of this slide, you can see the magnification of the two bones, and this could be, let's say, two parietal bones joining at the sagittal suture, although the illustration shows a coronal. It doesn't matter what suture we're talking about. No matter how close the bones are together, they are still separated by this microscopic thin line of connective tissue. And this is why sutures are considered a joint, fibrous joint, because that's the nature of the connective tissue separating the individual skull bones. Please remember, all skull bones are joined together by sutures. Now here's another example of fibrous joint, the syndesmosis. Let's talk about this for the bottom here. So here we see the alveolar process. We've seen this in maxilla and mandible. And then here's the item that we didn't say much about the teeth themselves. So teeth are made of dentin, not bone. This is why we're not mentioning them in the skeletal system. And this totally different material, dentin, which forms the body of the tooth, is held solidly in the alveolar process by a thin layer of connective tissue. This is called the periodontal ligament. So this is this thin line in between the tooth and the alveolar process. If you heard this name, periodontal disease, this comes from the fact that this periodontal ligament can be degraded, especially if remnants of food get caught between the gum and the tooth, and bacteria start to degrade that leftover food item, and then the periodontal ligament also suffers damage in the process. The name of this kind of joint is gomphosis. So this is immovable, and it's between the tooth and the alveolar process. Another fibrous joint, this is slightly movable. This is located between the shafts of paired long bones, such as the tibia and fibula in the leg, that is shown here, but it is also found between the radius and ulna of the forearm. So again, two bones are held together by fibrous connective tissue. So by definition, this qualifies as a joint. This interosseous membrane is an example of syndesmosis fibrous joint. So I'm going to go out from this screen sharing and show you a cadaver look of the radius and ulna. Yeah, let's see if I can find this. I think this is the one I was thinking about. So when you look at this image, you see the ulna. On top here is our carpal bone. So this is the wrist area up here. And take a look at this membrane between the two bones. When you look at the skeleton, there's nothing between the ulna and the radius. But clearly, when you dissect it out from the cadaver, or if you would look in our own forearm, we would be seeing this interosseous membrane. And please ignore the individual parts to this interosseous membrane. For us, we're just listing this as a fibrous type joint, a syndesmosis. let's go back to lecture slides share here. And so here's the interosseous membrane, explained a little greater detail. And then there's a set of cartilaginous joints. So these allow either little or no movement, and that's because bones are tightly linked to fibrocartilage or hyaline cartilage. So let's take a look at these cartilaginous joints. Here is the synchondrosis. This is exemplified by the joint of the first rib to the sternum, and here's this hyaline cartilage piece that forms an immovable joint. Symphysis, again, this is cartilaginous joint type. We mentioned this in the lab. Intervertebral disc was our example, but we also have one in the pubic symphysis. These are slightly movable joints. And then the last of these cartilaginous joints is the epiphyseal cartilage themselves. These are also called growth plates. So the bones grow in length because of the action of these epiphyseal plates. These are hyaline cartilage by tissue type. If you remember way back in chapter 6, we described the mechanism how bones grow in length. So that zone of hypertrophic cartilage is found inside here, and the chondrocyte cell division keeps adding length to the shaft. So because here we have two aspects of the bone joined together by cartilage, this is why epiphyseal cartilage's growth plates classify as joints. Because we have hyaline cartilage, this is why we call this cartilaginous. And so here is the last and most complicated class of joints, the synovial joint. And this is named after the synovial fluid that's found trapped in the joint cavity itself. All synovial joints are freely movable, although again, we'll be seeing limitations to that. So we do have not only the cartilage that brings a low friction surface to these joints, but we also have the joint capsule, which is lined by synovial membrane, and there is a synovial fluid that lubricates this joint for even for a movement with even less friction. When we look at the articular capsule, this is a tough fibrous tissue, and I'm going to come back one slide to show you this thick fibrous nature of the capsule. We'll be seeing in a few minutes that the intercapsular ligaments can be very, very strong and can connect bones to each other, like you see here in this example. So the capsule is not just a bag, but it also home for these strong rope-like ligaments. And these are the ligaments that in the tissues we classified as dense, regular connective tissue, very similar to tendon. So many synovial joints have additional features to hold the bones together. And so let's take a look at this. Let's talk about first the ligaments. Again, this is dense, regular connective tissue, super strong material. We have ligaments outside the capsule, and you already saw that the capsule wall itself had a ligament nature to it, but on top of it, we have extra capsular ligament. It means that they are outside the capsule. Take a look at this knee joint. Well, here's one extra capsular ligament way outside the capsule. This is a fibular collateral ligament, and take a look, it connects bone to bone. So here's the femur on top here, and it connects the femur to the fibula. On the other side, take a look at this long extracapsular ligament. This is the tibial collateral ligament. So the tibia is connected to the femur. These extracapsular ligaments contribute to the stability of this joint, especially the knee joint with its huge load and a very slippery surface. The joining bones can move on top of each other sideways or inappropriate directions, can dislocate. So to increase the stability of these joints, we have these extra capsular ligament. And then to boot, and this is not the only joint that has this, but there are intracapsular ligaments as well. If you heard about ACL, PCL injury, those ACL and PCL stands for anterior cruciate ligament and posterior cruciate ligament. You see their location here. So these ligaments are anchoring, again, the two bones together, the femur to the tibia, again, providing a greater stability for this joint. We also have a structure called meniscus. Here's the meniscus. This is a fibrocartilage disc, and it just increases the rim to this curved surface on the tibia, and that again prevents the easy dislocation of femur from the surface of the tibia. So all these structures added together contribute to the stability of the knee joint. Again, there are structures in other joints as well that function similarly. So you would not see these type of structures in the fibrous type or cartilaginous type joints. Let's mention here two really unusual structures, the bursae. So I'm going to come back here a couple of times, maybe right here. Imagine it right here in the joint capsule. This space would have a tiny opening, and there would be an extra bag out here outside the capsule filled with synovial fluid. Well, that is a bursa. And here is around the elbow joint. We don't see the inside of the articular capsule, but here is the bursa. So this is joining with the articular capsule, and so the synovial fluid is flowing into this blue bursa. What is a bursa good for? Well, think about your elbow joint as it's pictured here. When you bend your elbow, your skin stretches and it would push down on the bony surface here, or would push down on the articular capsule. So the liquid content of the bursa provides a dampening effect on that pressure from the skin as the elbow is bent. We also have lubricating structures between tendons and bones, especially in an area where tendons just run over the surface of bones. This is happening in our wrist area or carpal area. Take a look at these tendons here, numbered 2, 3, and 4. Those tendons are going towards the fingers, and the muscles in the forearm will pull on those tendons to move our fingers. Because these tendons run from the forearm all the way to the fingers, they have to go over the surface of the carpal bones, wrist bones. And in the lab, we have mentioned many of these, all of these carpal bones. And take a look on the outside. There's another series of tendons here. So the tendons, when they are protected with a sheet, the sheet prevents the rubbing of the tendons on the bony surface. If you heard about carpal tunnel syndrome, well, here's your carpal tunnel. Take a look at here, the carpal bones, and here's this tunnel where the tendons are located. So with the repeated pressure on these tendons or on this area in a particular ergonomic situation, it's not the tendons that start to get inflamed, but take a look at this yellow structure here, number 1. This is the medial nerve, and this nerve gets pressured during the development of carpal tunnel syndrome, and so changing the position of the hand, taking the weight off of the carpal area at a particular work position helps to relieve eventually inflammation that's causing the carpal tunnel syndrome. When it comes to types of synovial joints, all these came up in the lab. So let's take a look at examples. Here is the planar joint between the carpal and tarsal bones, really typical. But take a look at also between the vertebrae and the ribs. The rib movement during inhalation is carrying that movement in these planar joints. What's not shown here is the articular capsule, which will be covering a large area of the bony surface here. So this blue line is the hyaline cartilage on the bones, and the articular capsule, again, is not shown. This is a synovial joint, so it has to have an articular capsule. A hinge joint works exactly like a doorway, moving only in one particular plane of the body. So a knee joint, elbow, ankle. The interphalangeal joints mean the joints between finger bones. And we'll be coming onto these motions, flexing and extending. So those are the two types of movements that are allowed along these joints. So, for example, when you move your forearm towards your shoulder, that is a flexing of the forearm, and that's the only type of movement that's carried out along the elbow joint. So this is a hinge. These are examples of hinge joints. We had very few pivot joints in the lab. In the second lab, we may have mentioned the dens and the articulation with the atlas as a pivot joint. In the lab, we mentioned more specifically the head of the radius in the radial notch of the ulna. Although in the lab, we don't have these ligaments pictured, but the head of the radius is pivoting, moving the radial notch. This allows supination and pronation. We'll be seeing these movements in just a few minutes. The condyloid joints, the best example, we saw this in the lab. The head of the radius the distal end of the radius, making joints with two carpal bones, scaphoid and lunate, forms this joint. Again, the capsule is not shown here, only the hyaline cartilage-covered surfaces. We have now abduction and abduction type of movement as well here. really high range of movements of the thumb happens around the saddle joint. This is a uniquely designed joint between the metacarpal of the thumb and the trapezium of the carpal bones. So we can have opposition and circumduction. Again, saddle joint, we just have two in the body, one on each hand. And the most flexible and the joints with the highest range of mobility are the ball and socket joints. This is the shoulder joint or the hip joint. And we have flexion, extension, abduction, rotation. So these type of joints provide the articulating bones with the greatest freedom of movement. So in this next part of the lecture, we'll take a look at the type of movements. We didn't say a whole lot about these in the lab, although in a muscle labs, we will mention the angular movements by name, rotation, and even some special movements as well. So let's take a look at angular movements. Angular just means that two articulating bones move, and when they move, they change the angle between them. So think about the flexing of the forearm. We're starting from anatomical position, and so the angle between your forearm and the humerus is 180 degrees. When you flex your forearm, you are decreasing the angle all the way to like 5-10 degrees. When your wrist is touching your shoulder, you flex your forearm and you decrease the angle to single digits. This is happening in the sagittal plane. Flexing is always happening in the sagittal plane. Think about another flexing example, the femur, the coxal bone. When you step on a stair, you are flexing your thigh. It's happening, this movement is happening in the sagittal plane, and you are decreasing the angle between the femur and the coxal bone. Extension is the returning of these bones back to anatomical position. So let's go back to the example of the forearm. So you decrease the angle between the forearm and the humerus by flexing. To return the forearm into the anatomical position, you have to increase the angle all the way to 180 between the forearm and the humerus, and that movement is called extension. Again, this is all happening in the sagittal plane. Let's change the angle between articulating bones in the frontal plane. So again, think about the thigh, the femur. If you move your femur away from a midline, your femur will be moving laterally, sideways in the frontal plane. This is the motion called abduction. Abduction is returning the thigh, the femur, back into its anatomical position. Abduction again moves the femur towards the midline. Again, this movement is happening in the frontal plane. You can combine, especially at the ball and socket joints, you can combine abduction, adduction, flexing, and extension, and you get circumduction. This is a movement. You can move your arm, your humerus in a circle with respect to the joint of the scapula, and this takes advantage of the ball and socket joint structure, allowing the greatest freedom of movement. So here is a type of motion, rotation, we'll come back to that in the lab when we name the muscles that carry out these motions. So the example here is the shoulder joint. The humerus is moving with respect to the scapula. And when you bend your elbow at 90 degrees, and in anatomical position, you just flex your forearm to 90 degrees. But then from the anatomical position, move your hand to your stomach. And this is called medial rotation. What rotates here is the humerus is rotating in the articulating surface of the scapula. You can move your forearm sideways. Again, keep this 90-degree bend between the forearm and the humerus. And now you carried out lateral rotation. And again, what the bone that's rotating is the humerus, head of the humerus rotating the glenoid fossa of the scapula. We have a large number of special movements, elevation, depression, and protraction, retraction. Let's talk about the mandible in this regard. We'll be looking at the structure of the temporomandibular joint, and we will be able to see just how is it possible that not only you can carry out the lowering of the mandible, the depression, not only you can bite onto something, that is when you elevate your mandible, but you can also move your mandible forward, maybe about an inch or so, and then you can move it back to anatomical position by the movement of retraction. Our scapula can do this type of movement too, but the best is the mandible. Again, we'll be looking at the structure of the temporomandibular joint in a little bit, and we'll come back to that, to these special movements of the mandible. We also have special movements of the foot. This is a great example of inversion and eversion. So when you walk at the edge of your foot, you are moving the bottom of your feet medially, and then you carry out inversion. The eversion is the opposite movement. The edge of your foot is moving laterally, so the bottom of your feet is facing laterally. We also have this dorsiflexion and plantar flexion. So these movements, dorsiflexion, plantar flexion, inversion, eversion, are normal parts of the walking gait. Dorsiflexion happens when our heel is on solid ground, but our toes are lifted up. Plantar flexion, when our toes stay on the ground, but our heels are lifted up. Let me show you an example of this. And let's see. I think we're going to go with this one. So take a look at this album cover. This is the band that was super famous in the 60s, 70s, 80s. This group is called the BIOL, and they're walking across a crosswalk in London. I think it's London. But take a look at how they are placing their feet. Take a look at the dorsiflexion. With our forward-moving foot, we plant our heel. And in order to do that, we have to lift our toes. So take a look at 1, 2, 3, maybe a little bit here, 4 examples of dorsiflexion. So this is so natural, we no longer pay attention to this. And then take a look at plantar flexion. Toes on the ground, heels are lifted up. Here's a beginning position here, even more. And here is the best view of plantar flexion. So while you can do this on purpose, move your foot while you're sitting down, but when we are walking, running, these movements are naturally part of our walking gait. I just wanted to show you that we're not just making a list for the sake of making a list of these movements. They are part of what we do every day. We just don't pay much attention to, because once we learn to walk, the muscle movements are just carried out automatically. So let's go back to this sharing. We also have supination and pronation as special movement. The best example of it is a movement of the forearm. We mentioned this way back in the first chapter, that the anatomical position includes the pointing of the palms forward. So this is, as I described here, palm is turned anteriorly. So the anatomical position comes with the supination of the forearm. Normally our forearm is in a position where our palms are facing the thighs, and pronation is the opposite, moving the palms pointing posteriorly. So that's the pronation. Again, we take these for granted so much that we don't even recognize when we do these movements. Every time you look in you're searching in your backpack for keys. Every time when in the lab you reach for a bone, your hand and forearm needs to be positioned to pick up an object, and supination, pronation, also previously mentioned medial and lateral rotations are all part of this natural positioning of the hand to grab onto a particular object. Let's mention opposition. This is coming from that saddle joint between the metacarpal of the thumb and the trapezium bone of the carpal bones. As a consequence of that, we can use our thumb and touch the tip of all other fingers, and this is a special property. Opposition helps us to grab onto objects. Without this movable thumb, the opposable thumb, it would be very difficult to hold onto a utensil or a pen or car keys, so on. So in the last few minutes, I just want to give you a tour of joints and give a little more typical look to them. So you've been seeing bones in the lab and also images of bones here in this lecture. The articular capsule is very tightly positioned around these joints, and so those free bone ends are really seen when this joint is dissected. So take a look at the temporomandibular joint. So we know that the mandibular condyle of the mandible and the mandibular fossa of the temporal bone forming this joint, but when you look at it with the capsule attached, it's not clear whatsoever. So this capsule is covering a large area, especially when you have an additional ligament right next to that. This is the internal view of the temporomandibular joint. So you can see the mandibular condyle of the mandible, and you can see how this elevation and depression can be carried out by this the movement, the turning of the mandibular condyle. But protraction and retraction needs this articular disc in the middle. So this temporomandibular joint is a very complex looking joint because of this articular disc in the middle, and that disc allows gliding movements for the protraction and retraction of the mandible. I just want to show you a little example of the shoulder joint here. Not only that we have two bones, the head of the humerus fits in this very shallow depression of the glenoid cavity, glenoid fossa. We have muscles and tendons to stabilize this joint. And we also have a little extra growth of cartilage above the bony ends to make this joint a lot more stable. Some injuries are listed here. Rotator cuff injury. In addition to the supraspinatus muscle that is mentioned here, there are other muscles in the shoulder area that can be injured. We have 4 rotator cuff muscles. When a shoulder is dislocated, the humerus is moving anteriorly out of this shoulder joint. And the separated shoulder means that this acromioclavicular ligament that you see up here that is torn or stretched or damaged. Looking at a hip joint, it is interesting to see how many ligaments there are in addition to the joint capsule. This is also a good view of the obturator foramen here, showing you that it is covered by the obturator membrane. And when you look up here, this is the best way to see an intracapsular ligament. Remember, we had ACL and PCL in the knee joint. Well, here's a ligament that keeps the head of the femur attached to the coxal bone. So our femur has 2 of these types of ligaments, one on each end. I'm not going to say much about the tibio-femoral joint or the knee joint. It is a hinge joint, and I'm not going to go into detail about the patella. We didn't even say much about the patella in the lab or the joint between the patella and femur. So flexing, extending is a typical movement. This is a hinge joint and carries out movement only in the sagittal plane. And the last slide here is describing factors that affect a range of motion in synovial joints. Now, it's important to state here that when we talk about maintenance of homeostasis, the range of motion of bones also have their homeostatic value. Our forearm supposed to move at a particular angle when we flex the forearm. Anything less than that will disable us to some degree and limit our ability to move. Think about if the flexing of the thigh when we step on stairs would be limited. If that range of motion would be limited, we may not be able to put our feet in a car or step on a high stairs. So these type of range of motions not only have physiological values of angles for flexing and extending, but also we have diagnosis and treatment for those disorders of homeostasis, like loss of the range of motion. A lot of the times after a fracture of a bone, some kind of a tendon injury, or some other surgical intervention, the range of motion decreases, and physical therapy goes a long way to return the bones into this range of motion. So this is the tremendous importance of physical therapy. What factors can affect the range of motions? Think about normal range of motion. structure and shape of the articulating bone. Think about here the saddle joint formed by the metacarpal of the thumb and the trapezium. And on the flip side, think about two of the carpal bones or two of the tarsal bones, where the structure and shape of bones bring tremendous limitation to their movement. Ligament strength is important to prevent overextension. Overextension is a destabilization of the joint, and this is an undesirable change in the range of motion. Arrangement and tension of muscles, they can also limit. If you sit down on the floor with your legs stretched out, so when the knee is extended, the tension of the hamstring can limit how far you can reach. Or when you sit down on a flat surface with your legs stretched out, can you touch your toes? If you cannot, then the tension of the hamstrings, hamstring muscles and their tendons limit that. I want to mention one more, maybe two more here. Hormones, relaxin, which is a major hormone produced during pregnancy, increases flexibility of ligaments. This contributes to the loss of stability of joints during pregnancy. And disuse. Think about a person who has been bedridden or has been in a wheelchair for months. The ligaments and tendons become less flexible, and so lack of use of a joint with the muscles and tendons around it will also contribute to this decreased range of motion. So once this person recovers from a particular injury, ready to come out of the wheelchair, again, physical therapy is tremendously useful to return the range of motion to the expected homeostatic range. So I'm going to stop sharing here. Thank you for watching this joint chapter, and please remember, especially the second part of this joint chapter will be making a difference on lecture exam 3, because these movements we have not emphasized in the lab yet. So I'm going to do the unthinkable, stop this recording and put it in your flash shell. Have a great Thursday and the rest of the week, and I'll see you guys on the Tuesday, which happens to be the day of the practical. I'll see you guys later.